Welcome back to the deep dive. Today, we're doing something a little different, something very specific and, honestly, incredibly high stakes for a certain group of our listeners.
We are.
We're turning this session into a high-yield revision class. We want you to imagine that you're a postgraduate student, you're getting ready for your MD anesthesiology exams, and we're specifically focusing on the Gujarat University curriculum.
That's right. And the topic? Well, it's the one thing that stands between a successful surgery and a truly catastrophic postoperative complication. We are talking about sterilization and infection control.
You know, it's a topic that I feel students often gloss over, isn't it? They're so busy memorizing, the pharmacology of propofol or the physiology of the cardiac cycle.
They do.
That they forget to worry about how the instruments actually get clean.
And let me be very clear, as someone who has sat on the other side of that examination table, that is a fatal mistake. For today, I'm taking on that role. I am your senior faculty member, your internal examiner. And I'm telling you, if you do not know sterilization, you are a danger. Not just in the exam hall, but to your patients. In the exams, especially the Viva Voce, this is a favorite trap. It is a guaranteed topic in paper 1 or paper 2, and it is absolutely going to come up when you're standing there holding a laryngoscope or an LMA in your practicals.
Exactly. So for this session, you are the stern but hopefully helpful professor. Your focus is on precision.
Correct. This isn't just about passing an exam. It's about fundamental patient safety. If you kill the patient with a dirty scope, the depth of your anesthetic doesn't matter one bit. So we are going to unpack this examiner's trap. We're going to cover everything from the physics of the autoclave right down to the specific chemical you need to clean a fiber optic bronchoscope.
The mission is clear then. Cover the entire scope definitions, methods, monitoring, and the applied anatomy of the OT. We've pulled from the standard texts, Miller, Morgan, Anesthesia Review, to make sure the answers we discuss today are exactly what the examiners want to hear.
Precisely. Let's not waste any time. In an exam, you don't have time to waffle.
Okay, let's dive right in. Part A, Introduction and Exam Framing. Let's start with the absolute most fundamental basic. An examiner looks at you and asks, what is sterilization? You cannot just say cleaning things.
If you say cleaning things, you've already failed.
Yeah.
I mean it. You have to give the verbatim textbook definition. Sterilization is a process capable of removing or destroying all viable forms of microbial life.
All forms.
All of them, including, and this is the part everyone forgets, bacterial spores. And it has to be to an acceptable sterility assurance level.
And that level is a specific number, isn't it?
It is. You must say the number. It's 10 to the power of minus 6.
10 to the minus 6.
Yes. Miller and Anesthesia Review are very clear on this. What it means, practically, is that the probability of a single microorganism surviving on an item is less than 1 in 1 million. That is the standard. If you don't mention bacterial spores and you don't mention 10 to the minus 6, you haven't defined sterilization. You've just described cleaning.
And that brings us right to the most common point of confusion, the one you mentioned, sterilization versus disinfection.
This is where the Viva so often goes completely off the rails. Disinfection is a process that destroys most microorganisms, but, and this is the crucial distinction, as it's ordinarily used, it does not destroy bacterial spores.
So it's the spores. That's the dividing line.
That is the entire game. Sterilization kills spores. Disinfection does not necessarily kill spores, period.
So if I'm in the exam, I'm holding a laryngoscope blade, and I tell the examiner I sterilized it by wiping it with an alcohol swab.
Then I, as the examiner, will stop you right there. I'll probably just put my pen down. Alcohol is a disinfectant. It's a good one for certain things, but it does not sterilize. You've just confused a safety-critical definition, and your Viva is already on very shaky ground. You must be precise.
Okay, so why is this so critical for the anesthesiologist specifically? I mean, why isn't this just the CSSD's problem, the Central Sterile Services Department?
Because the anesthesiologist is the bridge. We're the ones who work in both the sterile field and the non-sterile field simultaneously. Think about it. 1 minute you're placing an epidural or a central line, which has to be perfectly sterile.
Maximum barrier, everything.
Absolutely. And the next minute you're managing the airway or putting in a peripheral IV, which is clean but not sterile. We are often the de facto infection control officer in smaller setups. Hospital-acquired infections, or nosocomial infections as they're also called, they're rampant in the ICU and the OT. If you, the anesthesiologist, don't know that your ventilator circuit or your laryngoscope is a potential vector, you are the one spreading VAP ventilator-associated pneumonia. You're the one spreading hepatitis B from patient A to patient B.
That's a very sobering thought. Before we get into the nitty-gritty of the methods, let's just frame this for the exam. What kind of question patterns should you be expecting?
Okay, good question. In the written papers, you'll see short notes. They love short notes on this. Things like monitoring of autoclave, plasma sterilization, or Spaulding's classification.
Yeah.
If you get a long question, maybe for 10 or 20 marks, it'll be something broader, like classify sterilization methods. Describe in detail the principle and monitoring of autoclaving.
And in the Viva?
In the Viva, it's always a table Viva. There will be an LMA or a Laryngoscope blade on the table. The examiner will pick it up, hand it to you, and simply ask, how do you sterilize this?
And you better know the difference between autoclaving it and just soaking it in Cidex.
Exactly. Your entire understanding is on display in that one answer.
All right, let's move on. Part B, basic concepts. You said definitions are very high yield. Let's drill down on disinfection levels. This is the CDC or Spaulding classification, correct?
Yes. Earl Spaulding created this classification system for medical devices based on their risk of causing infection. And this classification dictates the level of disinfection required. It's a very logical system.
So what are the levels?
You have 3 levels you must know. First, high level disinfection. This process kills all organisms except for high numbers of bacterial spores.
Okay, so it gets close, but not quite sterilization.
Precisely. It's used for what we call semi-critical items.
And give me an example of a semi-critical item, something we use every day.
A flexible endoscope, a fiber optics scope, or a laryngoscope blade. These items touch mucous membranes or non-intact skin, but they don't actually penetrate sterile body tissue.
Okay, what's the next level down?
Next is intermediate level disinfection. This kills vegetative bacteria, fungi, viruses, and very importantly, it kills mycobacteria, specifically M. tuberculosis, but it does not kill spores.
Then the final one.
Low-level disinfection. This kills most vegetative bacteria and some fungi and viruses. This is for your non-critical items.
Like my stethoscope.
Exactly. A stethoscope, a blood pressure cuff, items that only touch intact skin. Intact skin is a very, very good barrier against infection.
There are 2 other terms that always get thrown around in this conversation, antisepsis and asepsis. How does an examiner expect you to differentiate these?
It's very simple, and you must get it right. Antisepsis is the application of a chemical agent to living tissue.
Living tissue. Skin.
Skin or mucous membranes. Its purpose is to inhibit or destroy microbes. Think of chlorhexidine or betadine prep for a central line. Disinfection, on the other hand, applies to inanimate objects, the operating table, the IV pole.
Okay, so you use an antiseptic on a person, a disinfectant on a thing?
Correct. You never sterilize the skin, and you never use a disinfectant on a wound unless it's specifically formulated as an antiseptic. Asepsis is the broader concept. It means the prevention of contact with microorganisms. Asepsis is the goal we are trying to achieve through all these methods.
So to summarize it for an exam answer, antiseptic equals living tissue, disinfectant equals non-living objects, and a germicide is just a broader term that covers both.
Perfect. And the objectives of all of this, 3 things. 1, elimination of all pathogens. 2, prevention of cross-infection, so protecting patient B from patient A's bugs. And 3, safety. Safety for us, the healthcare workers. We don't want needle stick injuries or, contact with contaminated body fluids.
All right, part C. This is the real core of it. The methods of sterilization. This is absolutely essential knowledge. How do we classify these methods?
We can break them down into 2 broad categories, physical methods and chemical methods. It's a good way to structure your answer.
Let's start with physical. What falls under that?
Under physical, the big one, the most important one, is heat. And you have to subdivide that further into moist heat and dry heat.
Okay.
Moist heat includes things like boiling, which, remember we just said, is usually only disinfection, not true sterilization, pasteurization, and the absolute gold standard. Autoclaving. That's steam under pressure.
And dry heat.
Dry heat is what you'd see in a hot air oven. It works by oxidation of proteins. Or, in a lab setting, flaming a wire loop until it's red hot.
What other physical methods are there besides heat?
You have radiation. This is mainly gamma rays and UV rays. And then you have filtration, which is used for heat-sensitive fluids, or for air, like the HIPAA filters in a laminar flow OT.
And on the other side of the classification, we have the chemical methods.
Correct. Here you can think of it as gaseous sterilization and liquid chemical sterilants. The primary gas we use is ethylene oxide, or ETO.
Right.
The liquids are what we often call cold sterilization. This includes things like glutaraldehyde, which you'll know as Cidex, orthophthaldehyde, or OPA, and hydrogen peroxide solutions.
Let's break down those physical methods in a bit more detail. You said Autoclaving is the gold standard. Why don't we just boil everything if it's simpler?
Because boiling water at standard atmospheric pressure only reaches 100 degrees Celsius. That will kill most vegetative bacteria, but it does not reliably kill bacterial spores. To kill the spores, you need higher temperatures. And to get water hotter than 100 degrees, you need to put it under pressure. That is the fundamental physics of the autoclave.
We'll do a proper deep dive into the autoclave in just a minute. What about radiation? Where would an anesthesiologist see that in their daily practice?
You see it every single time you open a sterile disposable package. A disposable syringe, a commercially packaged spinal needle, an endotracheal tube. All of those are sterilized at an industrial scale using gamma rays, usually from a cobalt-60 source. It's got very high energy, very deep penetration, and it's called cold sterilization because it doesn't heat the product up, which is great for plastics.
And UV rays?
UV rays are different. They have very low penetration. They can't go through glass or even opaque plastic. So we use UV for surface disinfection or for air purification in the OT. You turn on the big UV lights in the room overnight. But you must remember, it requires direct line-of-sight exposure, often for more than 6 hours, to be effective.
Now let's talk about the chemical methods. You mentioned ethylene oxide. When do we reach for that?
ETO is an alkylating agent. It's very effective. We use it for items that are heat-sensitive or moisture-sensitive and can't survive the high temperatures of an autoclave. Think of the tubing for a heart-lung machine, plastic vascular grafts, or delicate rubber items.
What's the downside?
The main downside is that the cycle is very long, sometimes many hours. And crucially, you need a long period of aeration after the cycle is finished. ETO is toxic and carcinogenic, so any residue must be allowed to dissipate completely before the item can be used on a patient.
And then there are the liquids. Glutaraldehyde, we've all seen those trays of blue liquid in the OT.
Cidex, it's typically a 2% solution. Now here is a classic exam trap. If I, as the examiner, ask you, how long do you soak the fiber optic scope in Cidex? And you say 20 minutes, what have you just described?
Disinfection.
High-level disinfection. You're not wrong, but you haven't answered the question if I asked about sterilization. To achieve true sterilization, that is, killing the spores, you need to immerse that scope for at least 10 hours.
10 hours. I don't think I've ever seen a scope soak for 10 hours during a busy surgical list.
Exactly. And that is why, in practice, many chemically sterilized scopes are technically only high-level disinfected. There is a newer agent, orthoaldehyde, OPA. It's faster. It only takes about 12 minutes for high-level disinfection. It doesn't need to be activated like glutaraldehyde. But it has its own issue. It stains proteins gray. So if an instrument isn't cleaned perfectly, any remaining tissue will turn gray.
Okay, let's try and summarize the commonly used methods in the OT. If I have a tray of metal surgical instruments or a bundle of linen drapes.
Autoclave, without question. Steam sterilization is the first choice.
What if I have heat labile plastics or some delicate rubber tubing?
Then you're looking at ethylene oxide, ETO.
And for my expensive, delicate fiber optic laryngoscope.
There you have options. Glutaraldehyde or OPA for high-level disinfection, maybe sterilization if you have 10 hours, or the more modern choice, low-temperature plasma sterilization.
Tell me about plasma. That sounds like something out of science fiction.
It's the fourth state of matter. We're talking about hydrogen peroxide gas plasma, often known by the brand name Sterile. It works by using radio frequency energy to create a cloud of reactive ions and free radicals from hydrogen peroxide vapor. And this cloud of plasma just obliterates any microbes.
What are the benefits? Why would I use that over Cidex?
The benefits are huge. It's fast to done. A full cycle is usually between 45 and 75 minutes. It's a dry process. And very importantly, the byproducts are just oxygen and water. There's no toxic residue to worry about. It's excellent for complex scopes, camera heads, light leads, and even some batteries.
Okay, let's move to part D, the exam favorite, the autoclave. If you're sitting in the exam, you absolutely need to know this machine inside and out. Let's start with the principle.
The principle is simple: steam under pressure. But you need to explain the physics of why that works. As we said, water boils at 100 degrees Celsius at normal atmospheric pressure. But if you put it in a closed, sealed vessel, the autoclave, you can increase the pressure. And as the pressure goes up, the boiling point of the water goes up. But the real killing power isn't just the higher temperature. It's the latent heat of vaporization.
The latent heat.
Yes. Saturated steam holds a massive amount of energy, that latent heat. When that hot steam hits a cooler surgical instrument, it immediately condenses back into water. And that phase change from gas to liquid, releases all that latent heat directly onto the surface of the instrument. That's what instantly coagulates and denatures the bacterial proteins.
So it's the energy release of the condensation, not just being in a hot environment.
Precisely. There's another benefit, too. When steam condenses, it shrinks in volume by a factor of, over 1,000. This creates a local suction effect, a partial vacuum, that actively pulls more fresh steam into the pack. That's why steam penetration into wrapped bundles is so incredibly effective.
That's a fantastic explanation. It's not just hot air, it's the physics of the phase change. What are the main types of autoclaves we need to know?
2 main types for your exam. The older type is the gravity displacement autoclave. Steam is pumped in at the top, and because it's less dense than air, it pushes the heavier, cooler air out through a drain at the bottom. It's simple, but it can be slow, and air pockets can get trapped.
And the modern one?
The modern standard is the pre-vacuum or high-speed vacuum-assisted autoclave. In this type, a powerful vacuum pump sucks almost all the air out of the chamber before any steam is introduced.
So that solves the air pocket problem.
It solves it completely. When the steam is then injected, it instantly penetrates the entire load, even the densest of linen packs. This makes the cycles much faster and more reliable.
And now for the numbers, the parameters. I feel like I need to tattoo these on my arm before the exam.
You should, just memorize them. For a standard gravity displacement cycle, the parameters are 121 degrees Celsius at 15 psi, that's pounds per square inch, above atmospheric pressure for 15 minutes.
121, 15 psi, 15 minutes. Got it.
For a high-speed or pre-vacuum cycle, the numbers are different because it's more efficient. It's 134 degrees Celsius at 30 psi for 3 to 5 minutes.
Much faster.
Much, much faster.
What about this term flash sterilization? I hear that a lot.
Flash sterilization. Be very careful how you talk about this in an exam. The parameters are usually around 132 degrees for 3 minutes, but you must state that this is for immediate use only.
Like when a surgeon drops a crucial instrument mid-case.
Exactly that scenario. The instrument is sterilized, unwrapped, and must be carried directly to the sterile field. It is absolutely discouraged for routine use on full instrument sets because there is no packaging. There's no barrier to recontamination the second it leaves the autoclave.
Okay, so a quick summary. Advantages and disadvantages of autoclaving.
Advantages. It's the most effective, most reliable, most rapid, and most economical method of sterilization. Full stop. It's non-toxic. The only residue is water. And it has excellent penetration of fabrics and lumens.
And the disadvantages?
The main disadvantage is that it destroys heat-sensitive items. So no powders, no oils, and most plastics will melt. And, importantly for us in anesthesia, repeated autoclaving damages rubber. It makes it hard and brittle. The cuffs of your reusable ETTs or LMAs will eventually crack. It also corrodes carbon steel, which can blunt sharp instruments like scissors.
Let's move on to Part E, monitoring. This is critical. We've run the cycle. How do we actually know that it worked? You called this section exam gold.
It is, because if you don't monitor, you're just guessing. You need to describe the hierarchy of indicators in your answer. There are 3 levels.
Okay, what's the first level?
First, you have the physical or mechanical indicators. These are the gauges and printouts on the machine itself. The thermometer, the pressure gauge, the timer. The modern autoclaves will give you a computer printout of the cycle. This is your very first line of check. If the printout says the temperature only reached 110 degrees, the load has failed. It's that simple.
Makes sense. What's the next level up?
The next level is chemical indicators. These are materials that are designed to change color when specific parameters, usually temperature and time, are met.
Like the tape they put on the outside of the pack.
Exactly. That's an external indicator, like autoclave tape. It has white stripes that turn black. But, and this is a huge exam warning, autoclave tape only tells you that the pack has been through a heat process. It does not prove sterility, it just proves it got hot. A pack could be in an oven, and the tape would change color.
So it's just a process indicator?
Yes. That's why you also need internal indicators. These are multi-parameter chemical strips that you place deep inside the pack. These are much more reliable because if they change color correctly, it shows that the steam actually penetrated to the very center of the bundle.
You mentioned a specific test before, the Bowie-Dick test.
Yes. You must mention the Bowie-Dick test. This is a very specific type of chemical indicator used only in pre-vacuum autoclaves. Its sole purpose is to check for the adequate removal of air and to detect air leaks. It's a large sheet of chemical indicator placed in the middle of a standardized stack of towels. If there's an air pocket, meaning the vacuum didn't work properly, the steam won't reach the center, and the sheet won't show a uniform color change. It tests the machine's function, not the sterility of the load itself.
Okay, so we have physical, then chemical. What's at the top of the pyramid, the gold standard?
The gold standard is and always will be biological indicators.
Actual living thing.
Well, dormant living things. They are standardized preparations of highly resistant bacterial spores. The logic is simple. If your sterilization process can kill these super-resistant spores, we can be confident that it killed everything else, all the less resistant pathogens.
And we use a specific type of spore for a specific process, right?
You do. For the autoclave and for plasma sterilization, which are heat-based, we use the spores of Geobacillus stearothermophilus.
Why that one?
Because it's a thermophile, it's a heat-loving organism. It actively grows at 55 to 60 degrees Celsius. So if the autoclave can kill a bug that loves heat, it can certainly kill the common pathogens that thrive at body temperature.
And for the colder processes?
For ETO and dry heat, we use the spores of Bacillus subtilis, or, more recently, Bacillus atrophius. And the good news is we don't always have to wait 2 days for the culture to grow anymore. Modern biological indicators have a rapid readout system that can detect a specific enzyme from the living spores, giving you a result in just 1 to 3 hours.
What happens if there's a failure? The biological indicator comes back positive.
A positive BI is a major event. It means the spores grow, and therefore the load is considered non-sterile. You must immediately recall every single item from that load. It's a critical safety incident that requires a full investigation into why the sterilizer failed. The same goes for finding a wet pack. A wet pack is considered contaminated because moisture can wick bacteria through the packaging material.
Okay, let's make this really practical. Part FOT and anesthesia-specific applications. Let's talk about the tools of our trade. Laryngoscopes, a very common Viva station.
It is. So let's break it down. The blade is typically stainless steel. It's a semi-critical item because it enters the mouth and touches mucous membranes. Ideally, it should be autoclaved. If not, it needs high-level disinfection.
What about the handle?
The handle.
Ah.
The handle is the dirty secret of anesthesia. It is a major source of cross-infection. We handle it with our gloves, which may be contaminated, then we put it back on the machine. The handle should, at a minimum, be wiped down thoroughly with 70% alcohol, or another intermediate-level disinfectant between every single case.
And if it's a fiber optic blade?
Good question. The fiber optic bundles can be damaged by repeated autoclaving. It can reduce light transmission over time. Many places now use washer disinfectors or plasma sterilization for them. But if autoclaving is the only option, safety trumps equipment longevity. You autoclave it.
What about the laryngeal mask airway, the LMA, specifically the reusable silicone ones like the LMA Classic?
You can autoclave them, typically up to 40 times, but there is a massive exam trap here that catches so many students. You must fully deflate the cuff before putting it in the autoclave.
Why? What happens if you don't?
Physics again. Boyle's law, PV equals nRT. If there's any residual air left in that cuff, when the temperature inside the autoclave rises to 121 or 134 degrees, that trapped air will expand dramatically.
And pop the cuff?
It'll either burst the cuff or, more commonly, it will cause a weak spot to balloon out, creating a herniation. If you're in a Viva and the examiner hands you an LMA with a little bubble on the cuff, they know you don't understand the practicalities of autoclaving.
It's a great tip. What about our anesthesia circuits?
And thankfully, these are mostly disposable now. Single use is by far the best and safest option. If you are in a setting with reusable circuits, they are a nightmare to clean properly. They are typically pasteurized or chemically disinfected, but the corrugated tubing traps moisture and is a perfect breeding ground for bacteria like Pseudomonas.
And regional anesthesia equipment.
Absolute no compromises here. Epidural and spinal trays must be properly autoclaved. This is a critical item. You are entering the epidural or even the intrathecal space. Any contamination here can lead to meningitis or an epidural abscess, which are devastating complications.
Okay. Let's touch on infection control more broadly. Hand hygiene.
It is the single most effective measure to prevent the spread of infection. Period. End of story. Nothing else comes close. Alcohol-based hand rub is the standard for routine decontamination between patients. You only need to use soap and water if your hands are visibly soiled. You should be able to recite the WHO's 5 moments of hand hygiene if asked.
And barrier precautions.
This is another key area. When you're inserting a central line, you must use maximum sterile barrier precautions. That means a cap, a mask, a sterile gown, sterile gloves, and a large full-body drape for the patient. Studies have proven that this bundle of precautions significantly reduces the rate of Clabbe's eye central line-associated bloodstream infection. If you're just wearing sterile gloves and using a small drape, you are practicing below the standard of care.
Speaking of standard of care, that's a good transition to Part J medico-legal aspect.
Yes, this is becoming more and more important. Hospital-acquired infections, or HAIs like VAP, cladoci, and surgical site infections, are increasingly being considered never events by regulatory bodies.
Meaning they should never happen.
They're seen as largely preventable. If a patient contracts hepatitis C from a poorly cleaned endoscope, that is a clear case of negligence. As an anesthetist, you are professionally and legally responsible for the equipment you use. You cannot use the defense, "I didn't know the technician didn't autoclave it properly." It is your duty of care to ensure the equipment is safe.
How do you prove that?
Documentation. Documentation is your only shield. There should be logbooks for every autoclave cycle. Modern sterile supply departments have tracking systems that can link a specific instrument tray to a specific patient. If there is an infection outbreak, or worse, a lawsuit, that logbook and that tracking data is your defense. It proves you followed the process.
Okay, Part H, the final stretch. Exam integration. Let's try to visualize some of those comparison tables you mentioned. First up, sterilization versus disinfection. Quick comparison.
Okay. Sterilization. Spores are killed. Disinfection. Spores are not guaranteed to be killed. Sterilization has a sterility assurance level of 10 to the -6. Disinfection just reduces the microbial load. Sterilization is an absolute term. Disinfection is relative.
Good. How about autoclave versus ETO?
Autoclave. High temperature, 121 degrees or more. ETO. Low temperature, 37 to 55 degrees. Autoclave. Short cycle time measured in minutes. ETO. Long cycle time measured in hours, plus aeration. Autoclave is for heat-stable items like metal and linen. ETO is for heat-label items like plastics and delicate electronics.
Excellent. Let's do some rapid-fire Viva traps. I'm the examiner. I hand you a gum elastic bougie. How do you sterilize this?
The wrong answer is autoclave. It will melt into a noodle. The correct answer is it's heat labile, so it requires a low-temperature method like ETO, or it can be high-level disinfected with chemicals.
Good. Next question. Doctor, we're in a rural setting and the autoclave is broken. Can we just boil the instruments for this emergency case?
The safe examiner-approved answer is, sir, boiling provides disinfection, not sterilization, as it doesn't reliably kill bacterial spores. It would not be acceptable for critical items entering the bloodstream or a body cavity unless in an absolute mass casualty disaster scenario where no other option exists. The standard of care requires sterilization.
Perfect. Last one. What's the minimum contact time for glutaraldehyde?
And if you say just dip and wipe, you fail on the spot. You must specify. For high-level disinfection, the minimum time is around 20 minutes. For sterilization, it requires a prolonged immersion of up to 10 hours, depending on the manufacturer's instructions.
And finally, diagrams. What should students practice drawing for their written paper?
You should be able to draw a simple schematic of an autoclave. Show the inner pressure chamber, the outer jacket, the steam inlet at the top, the air and condensate discharge at the bottom, and the safety valve. Also, draw the pyramid of monitoring. Physical indicators form the wide base at the bottom, chemical indicators are in the middle, and the single biological indicator is at the very top, the peak representing the gold standard.
And for structuring a long answer?
Always use a logical flow. For a 10-mark question on autoclaving, start with the definition of sterilization, then the principle of the autoclave steam under pressure, latent heat, then the method describe the types and parameters, then, crucially, end with monitoring. Definition, principle, method, monitoring. That structure will get you marks every time.
This has been an incredibly detailed and, I think, very valuable review. Let's summarize the absolute key take-home points for the exam.
Okay, 15-second summary.
Sterilization means killing spores, 10 to the -6. Disinfection does not.
Spaulding's classification critical, semi-critical, non-critical dictates the method you must use.
Know your autoclave numbers. 21 degrees for 15 minutes or 134 for 3.
Monitoring is not optional. Physical, chemical, and biological. Biological is the best.
Deflate the LMA cuff before autoclaving. Clean the laryngoscope handle between every case.
Hand hygiene is the single most important thing you can do. And finally, my most important piece of advice. In the exam and in life, if you are unsure if an item is sterile, then it is not sterile. State that clearly. Prioritize safety above all else.
The invisible work of sterilization is the foundation of surgical success. I really like that.
Right.
Thank you, Professor. I mean, expert speaker, for that grueling but absolutely necessary review.
My pleasure. Go into that exam with confidence and prioritize safety in your answers.
And to our listeners, next time you're in the OT, try visualizing that autoclave cycle. It might just save your Viva. Keep studying, and as always,
Keep it sterile.
and keep it safe.